Thank you very much, and it's an honor for me to be here. I think I need to share my slides, and if somebody will allow me to share, I really appreciate. And thank you very much for giving me this opportunity. And it's my great honor to be here with all of you and talking about what is the AI and what is the future at the horizon, and how this can open the doors of a better delivery of care for our patients. So my talk today is just to talk about emergent artificial intelligence and how can we improve precision assessment management in IBD. So I will start by saying what are the important targets in IBD in 2026? Definitely the target we know very well. We move from clinical remission to biochemical remission, endoscopic remission. We want more deep remission with histologic, and we will see also the future of the intestinal barrier, which is now a new therapeutic, in IBD, and all the precision medicine of molecular remission, and all enabled by AI. The same target that we have in clinical practice and all the questions that we want to answer in the future are the same for artificial intelligence. And you can see in IBD, so we have developed, and I will show, and we will through this talk, about a different kind of model for clinical, for endoscopy, and histology. However, our goal now has changed. We want more, the third dimension of the deep healing with the barrier healing and the endo-histo-barrier omics, because deep remission is a better outcome for our patients. So let's see to date what we have developed. And if we see the current status of AI in inflammatory bowel disease, we have developed a model for diagnosis, for monitoring, for surveillance, also for detection, characterization of this dysplasia, despite still we are far away. But the most important things, which I think everybody is wants to achieve this goal, is the AI for outcome response to therapy prediction in clinical trial and clinical practice. But when we look at the next generation of the AI, you can see then we have the future is bright, and which is almost the present, I'm saying. There is the endo-histo-omics, the fusion, the integration of machine learning for better, because the disease is not just, it doesn't fit all patients, so it's different for every patient, the mantra, the right treatment for the right patients. We will talk about, I will show you the emerging intestinal barrier, how it's important. And then also I touch a little bit about the monitoring with wearables, and I will not talk about large language models. But there are still a lot of expectation and concern, and concern comes from the industry, concern comes from the regulatory bodies and patients and physicians. We can't forget now about also environment, sustainability. And then in the end, I will show you what is, I will show you the, the roadmap for the clinical implementation. So to date, if we look at here, why AI is important and how can we implement in IBD clinical practice? Definitely for disease assessment, outcome prediction, response to therapy prediction in medicinal medicine. I mean, the specific, our goal is to standardize objectively and efficiently disease assessment to accurately and rapidly predict outcome response to therapy, to also automated barrier evaluation, because it's important for the new development of the new drugs, to prompt, detect, and characterize the lesion. And then the present, the most interesting things that we have in AI now is the integration or interactome of multimodal and harmonized data. So when we start with the endoscopy, then this is one pillar important and probably comes soon and just already in the eye in endoscopy. This is what is the armamentarium. So when we look at what we have definitely this virtual endoscopy, dichromy endoscopy, but then we can see also at the level, at the microscopic level with endocytoscope, the ultra-high magnification scope, and the confocal laser endomicroscopy. However, all these fancy technology and tools, they are prone to subjectivity in terms of cerebral variability, expert only, and so the artificial intelligence can overcome this limitation by favoring endoscopic assessment in a standardized, objective, rapidly way, and also to predict outcome and prediction and response to therapy. Indeed, if we look at one of the first model, I can't share all the model, but, I will share some of my work that I think is important. This has been in collaboration with Professor Maeda. Professor Maeda spent 18 months in Cork, and you can see here, then it's everybody loves in ulcerative colitis, the Mayo. But what is important, of course, we consider thousands of colonoscopy, thousands of imaging. But what is important for an AI is not just the sensitivity, specificity of the diagnostic performance, but also to predict relapse. And you can see also interesting how the AI outperform the physician. So this is the model how it works. Everybody loves, I think, Mayo. Everybody probably use, I hope so. And so it's just in the withdrawal time, in a simple way, they tell you what is the Mayo. And of course, this will help to optimize your therapeutic management in ulcerative colitis. But we know very well then the white light misses some granularity of the disease. And indeed, we developed the Picasso score. The Picasso score was built to just looking at the vascular, the mucosal architecture, then give us the opportunity to capture this mildness, because also the mild disease predict flare-up. So we have developed the first virtual endoscopy eye by building the Picasso score that you can see here, and we apply white light in the virtual endoscopy. And you can see clearly then the predict, the performance of the eye was better in the virtual endoscopy, especially to capture mildly disease and also predict outcome prediction. So now, moving forward, we have developed this AI switching. What does it mean? Then simultaneously can be multimodal. It means then you can, with this algorithm, doesn't matter which kind of scope do you use, this will give you the opportunity to switch from a model and others, from, iScan, from NBI, from Bill Light, and you can see the performance we have done in iScan mode, in NBI mode, and you can see how the performance is very good in terms of sensitivity, specificity, but also to predict outcome. When we move on but what is now, we talk about score, but we don't want score anymore. So we want to talk about AI multispatial mapping. What does it mean, multispatial mapping? It's just that we want all the disease to be assessed in all the column in real time, because this definitely will capture granularity, and this is a big, fantastic work done by Stidham, and has been reproduced also in Crohn's disease, which we know we have done a lot in ulcerative colitis, less in Crohn's disease, probably limitation related with the transmularity of the disease and then require cross-sectional imaging. And you can see here with the new model of the segmentation model or the SAM models, he has developed in the ulcers in the spatial mapping the ulcers in Crohn's disease. So this is what is happening in the endoscopy. What will happen, and also we are now running this study. The study is Monet, probably will be the new generation. So we were using the new RDI, TXI, and NBI to predict, so to assess disease activity and to predict outcome, but also focusing on what I believe is important, especially to predict granularity of mild patchy disease, is the vascular changes and the vascular barrier. When we move to the histology, so the histology definitely is here. The digital pathology is important. And because we want to standardize objectively and efficiently disease assessment, we want to accurately prompt doing tissue segmentation. But what I will show and what we have done, we're doing much better now. Then we have done also we can cell detecting, so we can differentiate the cell from neutrophils, eosinophils, plasma cell, and also characterize and quantification. And we have done this, the recognition of the cutoff. Now we're doing also in the goblet cell, but because, for just predicting response to therapy in clinical trial and clinical practice. One of my pioneering work was this. And you can see then we were the pioneer on the eye in histology in IBD, and we were able to, identify, first we developed the Picasso Histological Remission Index based with a very thorough methodology. We realized the neutrophils were really important for predict activity of the disease. And you can see we couldn't just annotate the pathology of the neutrophils. The eye detection completely overlap precisely. And then in the same, you can see what is the outcome. Excellent. So that in terms of all the validated score in ulcerative colitis, in terms of outcome. So this can be a tool that can be considered also in clinical practice. Looking just at neutrophils, it's easy, especially when you have an overload of biopsies. But what we are proud of is this. So we were able to move forward in looking not just at the detection, but also the quantification and the cutoff to response on clinical trial, on phase 2 clinical trial of Marietta. And you can see here we have developed two models. One for tissue segmentation, so to identify epithelial and appropriate Scripps lumen, but then also neutrophil detection and quantification. And you can see here what is the detection, the performance was good for detection and quantification, but then we have developed also a cutoff to predict disease activity, which it's important and open an important door, especially to predict response at week 12 and 52 of the clinical trial. How does this translate? Think about in your clinical practice, you can develop these tools for cutoff, but at the same time, so you can just, avoid, you can improve your clinical trial design and also, for the future. So, but then we said, okay, how can we fuse? How can we integrate? Why is important? So we know very well the endoscopy language is completely different to the histological language, but we know that the histology is the gold standard and not the endoscopy. So in fact, we have integrated, and because we want an accurate and deep disease evaluation. And so with the same data of the phase 2 of ulcerative colitis, the Marietta data, we have fused the two endoscopy and histology, and you can see then interesting, the fusion outperformed in single endoscopy and histology and predict better in terms of histological improvement, histological remission, the prediction of response. So this is what we are going. And now, but what is important, because we are in the era of precision medicine, the right treatment for the right patients in the right moment, what is important is definitely what is, in terms of past. So the past was the clinical endoscopic histological phenotype. The present is the molecular, and the future is the integration. But why this integration is important? So why we need to add a pillar of omics and doing the endohistomics for predict outcome response to therapy? Because this is what is the concept of precision medicine. We think, we believe that with the eye, we will be able to do that. And we can be able to look at the molecular subtypes. So in the past, and this is the therapeutic ceiling, or all doesn't fit, every drugs doesn't fit all. So you can see in the past, we work in this way. We thought then, One drug works for everything, single targets, but it's not true. So we need to now integrate it, all the endoscopy imaging, all the molecular tools, because this will help us definitely to create cluster of patients. The cluster of patients, they can respond to certain drugs and not to the others. What is the new frontiers of AI in IBD? Definitely the eye intestinal barrier, which is one of, in the moment, an important field of my research, the endohistomics, which I told you, and then we touch a little bit the lesion detection, molecular characterization in IBD, and then as I say, the wearable device, and I will not touch the large bowel. Why the barrier impairment is important in IBD? So it's important because it plays an important role in the pathogenesis of the disease, and the most important is related, what is the symptoms, the urgency of the patients, and the quality of the care. So if you will look at here, the barrier, indeed, you can see when the tight junction, when we have an impairment, the bacteria get in, and definitely they start with this orchestration of the cytokine inflammation. In the same with impairment, we think about only about epithelia, but we can't forget the vascular, which the vascular is most important for the brain-gut axis and with the symptoms of for patients, translating in urgency, depression, and anxiety. With the advanced technology, so this is ultra-high magnification endocytoscope, which give you the opportunity to enhance 500 to magnify or 520-fold, you can see definitely basals, epithelial, and global cell. And the same you can do with confocal microscopy, which is more functional and give you also the, after injection of the fluorescein, will give you the opportunity to look at the, leakage. We know very well, we have pioneered this, we have done, we have automated the multispectral spatial imaging by seeing the mean expression and Excel mean expression of the tight junction. Initially, we started with JAMA, Claudin 2, and Euclidine, combined with the ultra magnification. So combined with the defect of impairment seen in vivo on the patients, but at the same time targeting biopsies. And these are the results. You can see then the combination, the combined cytoscope with Claudin 2 was important to predict in an automated way to predict outcomes in IBD. So just to let you know and give you an example, this beautiful art about spatial multispectral imaging, you can see this is art. We can just, see the tight junction, different colors. But then we move forward and say, okay, but this is difficult. Not everyone can use that. So we have automated, and so we are working on this. I will give you some preliminary data that have been unpublished, but have been presented. And you can see we couldn't do, just automated, not just for the epithelial barrier, but also for the vascular barrier. And this is with endocytoscope and also with confocal endomicroscopy. And indeed, these are the preliminaries, and also we have done all automated multiplex for all the tight junction. Then we have realized then PV1 in the vascular and the Claudin 2, they are the most important protein. So this is just to let you know, this is unpublished data. You can see we have done automated AI for endocytoscope, which fantastic, let's say with good results for being a difficult procedure. At the same time, we've done also with the confocal endomicroscopy, and you can see then with very good results also in terms of single features. So this what it's but because we want to do endohistomics and because we want to do the endohistobarrieromics, we have also added the layer of the gene, and you can see with the confirmation as a PV1 and Claudin 2 important. Claudin 2 more important for ulcerative colitis, PV1 more in Crohn's disease, which is justified by the fact that Crohn's disease is a transmural with a good prediction of outcome. And you will see now we are presenting new work, exciting work on the ESGE and probably ECCO 2027. So why the barrier is important, like I told you, because now there is a lot of effort to develop this new nanoparticle therapy. Then they are targeting the sealing of the barrier and seal, restore, and in combination with the biological therapy or advanced therapy. And then and you can see the restoration, which is important. Another thing that then I want to touch is our work on Prosper. And this is an Emsley grant in the early postoperative recurrence in Crohn's disease. And it's interesting, the nasal-enabled multimodal assessment. So we are excited to say that we have just developed the first, automated AI for postoperative recurrence in endoscopy, also in iOS. And the future is to create a multimodal machine learning to predict early recurrence and progression outcome of the patients. So this is to give you an example. We have improved a lot. The results are not here. We are submitting the ESGE. Initially, we did a semi-automated AI in ultrasonography, in a small bowel ultrasonography to assess postoperative recurrence, looking at bowel identification, techniques, stratification, also vascularization, lymph node. And these are the results. You can see we've done manual annotation, and the automated AI had a good correlation between automated and semi-automated and the physician. But now we have developed an AI completely. Then we will submit, hopefully, to present at ESGE in October. Just the little touch about the eye detection and characterization of the eye. Still concerned about, because the eye lesion, they're very difficult, they're so the morphology variable. So, but you can see here there is a detection characterization. You can do also with this endocytoscope and to see what is this is more work done in Japan. The same also the eye-driven histological analysis with the P53, and the future definitely is the personalization by adding also molecular markers and also AI guiding surgery, organ sparing. So this is something that has been developed in evolution by the UK team, the UK people, where you can see this algorithm could detect and characterize the lesion. But I think where we're going probably is more this. I think because of the variability, the difficulty of standardization, I think you need to use yourself as well trained. I think you need to use probably more histological, so, and maybe the endocytoscope or other toys that can see in real time histology like this, and with an AI standardized, added, included, and can help definitely to combine what is the histology and the endoscopy. So, and finally, the wearable. Definitely, I'm very excited on this. I've not done myself still at work, but I have a good institution here. The name is Tyndall Institute, and they have got a big grant now, and hopefully we can do the same using this little fitness tracker or smart t-shirt, or just to assess some little things like sleep data, histological remission, biomarkers, pain levels and anxiety, just to predict flare-up. I like very much this wearable identify and predict flare-up on the patients 7 weeks prior. And I think the flare-up, and I think this is the way to go. And just based on the oxygenation, heart rate, the steps, I think it's interesting. And now the same authors has done also the for sleep, you focus on the sleep. So just to conclude, what is available, what is experimental? I think this is a very nice overview in terms of what is now for sure is endoscopy, histology. What is almost the future, I think, will be more machine learning, wearables, and also this intestinal barrier. But there is still a lot of things to do. We are working with the societies, so we're trying to standardize. And you can see the roadmap. It's definitely reproducibility, reliability. data governance, which is really important, this and avoids disparity. The training, so also it can be the medical education is important. We need to collaborate because I think we need to work and create a very nice international AI consortium, which we are doing. We need to be simple, and then we need to reproduce with validate with randomized control trial. And so I will define my vision of the future with this. There is precision endoscopy, but I think it's precision medicine. And you can see then everything is important from advanced imaging for artificial intelligence, for omics, for histology. But what is important is the stakeholder. Then they are part of your team, which I'm building, which they belong to me like this: expert endoscopy, expert histology, AI engineering, expert biologist or scientist, and expert pathology. Only this, approach can definitely help us to move on in the wonderful future of the eye for improving care on our patients. Thank you very much, and I'm open to the question.